And the session is open for questions. Great, so we see microphone number one.
Yeah, Otis Brawley from the American Cancer Society at Emory University. I'm a medical oncologist and epidemiologist. Just a couple more comments for Dr. Ferryman. I think any discussion about research in minorities should always note the following fact. In the terms of breast cancer, there are several studies that show that 5 to 7% of black women with breast cancer diagnosed as localized in this country do not get surgery within the first 2 years of their diagnosis. And that was research from 1896 in Halstead. I don't think he had any black patients in his study, but I don't think any of us would say that those black women should not be getting therapy. What my point is, there's a large number of blacks in the United States who do not get appropriate therapy right now. Sometimes they don't get appropriate therapy because they start saying, well, there were no blacks in the trial. My question is, I'd like to ask a statistician to talk about subset analysis and using race by subset analysis, because when I was taught to design clinical trials, I was told subset analysis should be done very rarely and should be viewed with suspicion. And I'm reminded of one subset analysis that was done by race. I was involved with this in the late 1980s, early 90s. We did a subset analysis on an AZT study for HIV and noted erroneously that the blacks who got AZT did not have a good response. We subsequently noted that they did not have a good response because of socioeconomic reasons, they were less likely to be compliant in taking the drug. Did publish that, but the first message that we published, which was that AZT was more effective in whites, is still what I hear about 30 years later. I don't hear that we found out that AZT was ineffective in the black population, a black subset, because we found that they were non-compliant. So my point there is it can go both ways, and you can harm the public health by doing these subset analyses just as you might be able to help them.
Dr. Katsonis, would you like to address subset analysis and race and ethnicity?
Okay, that's not something that I thought would come up. I mean, subset analyses are done and are presented typically as exploratory analysis unless they were pre-specified. So all of these things, I mean, that's typically how things get reported these days, and you report it as an exploratory analysis, and that's it. There's no real prohibition against it. It's more like don't blow it out of proportion and present it in. Present the evidence as to, in the hierarchy in which you had it in the study. But there's no ban on subset analysis. I definitely take your point that if you do a subset analysis for something surprising and you don't look deeply into it, if you didn't have adequate power for it, if you didn't have enough assessment of the facts and so on, and then you present it as a real event, then you'd be misleading a lot of people, and that exactly could have happened exactly then.
I think some people say that it's hypothesis generating, subset analysis.
Right, but if it's never tested, which is I think the problem that we face in a lot of studies, in the land of oncology where one decent sized study is enough for FDA approval and a subset finding is made, like how commonly do we then see that subset hypothesis actually pursued?
I mean, there are many examples. One I've seen recently was there was a drug and it was for something else, and it seemed to also help with something else. Well, it didn't help for the main thing, but it was kind of helping for for the other thing, and that other thing became the headline and so on. That's not, I mean, this is the kind of subset analysis going really wrong. But there could be a signal there, just a matter of following it up, rather than saying you have the home run right there and then.
And I also want to comment on something sort of embedded in your comments as well, where you said, well, the reason was non-compliance of the drug, why there was these kind of different results. And I think even that, even though you mentioned that that wasn't what was sort of taken up and used and more commonly well known, even something like that, I think has the potential. You said in your comments, non-compliant because of social factors and social influences, right? But again, someone could just hear non-compliance, and without that additional context of, well, why is there a non-compliance, right? Again, that's another example of how even if you do have an analysis that has the adequate power and things like that, right? That if what's kind of being put in the forefront is something like non-compliance in this particular group, without that additional context and explainer, we can get to some potentially kind of tricky areas. So yeah, just wanted to add that.
Thank you. We're going to move quickly from microphone to microphone because we only have about 6 more minutes left. But microphone number 2, please introduce yourself and your question.
Yes, John Gordonier. I now call myself a research ethicist. I'm a scientist, but a scientist with a Doctor of Business Administration degree and experience in data system design and management and the mathematics of using them. And there are 2 things that concern me in almost every meeting that I come to at National Academy of Medicine. I call ground truth versus data. Very frequently, there are data elements in data systems that are not at all what they purport to be, because the system of generating the data is inherently deficient and there's no quality control in the data system. Let me give you 2 brief examples. I looked at my own health record, which was converted from a very long military history, Navy, into an electronic record. There was a strong bias for putting things in, making sure they didn't overlook anything chronic. So a lot of things that were acute elements went into that. There were also misdiagnosis of acute elements. In my particular case, I had a misdiagnosis in acute episode described in the electronic health record as a chronic condition. The condition was never there at all. Another one, my wife, with the same last name, had a health finding in an examination which was not placed in her record but was placed in mine. So the data record was quite deficient. I worked for NCHS. Cause of death data, you may or may not know, is very variable as to its accuracy. You have incredibly untrained people filling in death certificates, and you have incredibly well-trained people doing a marvelous job. And if you really want to study cause of death, you have to do an awful lot of work. Now, I suggest that in looking at a data system, you really need to have somebody look at how was the data conducted, how was the data system put together. Very often you would find it was done by a very low-level person because they didn't want to put money into the effort, and that person was told to do it as a side thing when they found some free time, and was viewed as a distraction from their normal duties, and they had no training in data recording. So my question to you is, do you really believe that you can trust the data that you're using? Have you checked how it was created and whether or not it is credible?
And let me filter that question and pitch this to you, Dr. Katsonis. You mentioned variability in these systems. What proportion of variability would you ascribe to data integrity or data insecurity that Dr. Gardner just brought up? How much is the variability is due to data and how much is due to method? Can you even guess?
Not in general. There are databases that are constructed and checked, and there are many databases that have a lot of errors in them. So your points are right in that sense. The issue I was talking about, variability, had to do about images in terms of their quality and whether the algorithm performs reasonably well. Depending on how the image was taken, how it was reconstructed, et cetera, and so on. It was variability due to technical factors, but many of them go back to the quality of the image, which is sort of the same thing which is similar to the actual fidelity of the data in a clinical database.
Yep.
But that's what I meant about variability. That stuff hasn't been done, and obviously it has to be done if you're going to claim that something is doing well with images of a particular kind.
Yep. One more question over here. You have a question? Microphone 2.
My name is Dr. Roy Jensen, and I'm the director of the Cancer Center at the University of Kansas. Before I became a fully differentiated useless administrator, I was a practicing surgical pathologist who, in conjunction with David Page, ran one of the largest breast pathology consultation services in the country. And that's a background to my comment, which I'd like to get some response from the panel on, is that in our experience, both David Page's and my experience, the concept of relative risk was extremely dangerous when you're talking with patients, clinicians, family members, whatever, because there's always somebody out there who is ready, willing, and able to misinterpret that. And that in our practical experience, it was much better to talk about absolute risk over a defined period of time that was connected to a particular study. Because many studies, their value is only for a particular period of time. So I'd like to get feedback from our panel members if that's been their experience as well.
Yes, I agree 100%, and the literature bears that out. I mean, studies of risk communication all end with the suggestion of talking about absolute risk rather than relative risk, and also being very clear about what time period you're talking about, and really trying to help the patient understand how to interpret it, because numbers can be interpreted based on so many factors other than those numbers themselves. They're not delivered in a vacuum. So it goes back to Dr. Ferryman's point about context. People bring a whole lot of context to their interpretation of those numbers. I think you do need to be very, very clear. Yeah.
Wonderful, great. Well, if everyone would join me in another round of applause for our speakers. Oh, we have run out of time, but you are welcome to come up and talk to the specific speakers. We are now on a break, coming back at 1 o'clock for the data discussion.